Good afternoon. I'm Sandy Lozo, your practice support liaison at RCMA. Thank you for joining us for our ABCs of ACOs webinar. I'd like to thank Aledade for sponsoring this presentation. Our presenter today is Dr. Evan Saulino. Dr. Saulino is a family physician and the West Coast Regional Medical Director for Aledade. He works with independent primary care and multi-specialty practices from the Mexico border to the Canadian border and everywhere in between. Dr. Saulino has spent more than 20 years serving patients in continuity primary care and has been a clinical advisor to state governments trying to foster a stronger primary care system and has played key roles in multi-player efforts to move towards a sustainable strategy of value-based payments that support quadruple aim outcomes. Welcome, Dr. Saulino.
Thank you, Sandy, and thanks to everyone for making the time to tune into the discussion, to the presentation today. As you've heard, again, I'm a family physician. I've been in continuity primary care for more than 20 years, seeing patients and then trying to connect the dots between policy and practice and payers and everything, just to try and make the primary care system and the specialty system, healthcare system in general work better. I joined up with Aledade a couple of years ago because I really saw that there was a need, especially post-COVID, for independent practices, multi-specialty practices, community health centers, rural health clinics. All of those folks really needed a more support, and we couldn't afford to lose those folks. And so the discussion we're having today about ACOs sort of fits into that area of how do we try and ensure that primary care, that patients are better served by the healthcare system in general, and start to align what we do with what we say we want. Here's our learning objectives today. So first of all, again, I use the word value-based care, value-based payment there. We're going to learn a little bit about the tenets of value-based care, specifically around primary care. I mentioned the word ACO, Accountable Care Organization. We're going to learn about ACOs a little bit and the difference between physician-led ACOs and other ACOs. Again, we'll talk about sort of putting those pieces together of value-based care and ACOs. What does that really mean? And then really talk about sort of the tools and learning that we are seeing happen as we work with more folks and they figure out ways to do this effectively and ways that we really shouldn't pursue this. So sort of how do we make it work and sustainable overall? We'll start to dig in and talk about sort of where things are right now. And again, primary care, like a lot of the healthcare system, but primary care being that first contact place, the place that didn't have a lot of funding and resources prior to COVID. Right now, primary care is in trouble, right? And needs a lot more support and ideas and innovation, and it's sort of a vision to help us carry forward. And so, again, the reason I'm doing this work is because I've been working in this space, and I realize the unique role that Aledade can play working with practices that really do form the foundation of primary care for our communities. And so that's, again, why I'm here talking to you today. I grew up in Riverside. I went to junior high school and high school in Riverside, and really, again, identify with the communities that I serve. And so, as we talk, as I present today, really, I want you to understand that foundation in terms of why I'm talking with you today. So, again, right now, as you're listening, as you're taking this in, my question would be, what is your practice focused on right now? If you want to type things into the chat, that's helpful for us to understand. But challenges are numerous and really significant, right? If you are independent, how do you maintain your independence rather than sort of being bought up by whatever financial entity? how do you actually have usable technology and data that just doesn't add sort of another layer of stuff and too much information, but actually makes it meaningful and usable? How do you juggle things like meeting the bottom line and paying, your staff with all of the uncertainty with patient, fee for service and overall declining reimbursement on a per patient basis across multiple payers for primary care specifically? Workforce shortages, we hear from everyone. Workforce meaning like primary care clinicians, as well as everybody else in, like from medical assistants, front office staff, nurses. We need more folks in primary care overall. And like a lot of folks in the economy right now, folks are struggling with workforce shortages, and there are some innovative solutions that may be helpful there. And then those last two pieces of patient engagement, where we want to understand who are the people who need us most, and how do we actually reach them most effectively, given that we don't have adequate staff and we don't have a lot of people who can call patients and that sort of thing, as well as how do we balance the needs of everyone else who is pulling us from the payer side? Everybody has different metrics, everybody has different things that they want you to meet. And many of us start to feel like those things start to pull us away from actually interacting with patients and solving those problems that are really in front of us. So all of those things are the things that we hear from the practices that we work with, that I hear when I go and visit with practices and try and help them do this work. And given that myriad of things, it's important to think about how would doing something different actually help one or more of these areas, and again, improve practice rather than adding something on top of what is already, again, a lot of difficulty out there. So that gets to this discussion. So I mentioned the terms value-based care, which in a nutshell is moving from paying for the volume of services provided to the value that those services give in terms of keeping people healthy, keeping people away from unnecessary or high cost things that are especially unnecessary services, and really making sure that people stay healthier. If you're paying for that instead of sort of services piecemeal, as a fee-for-service system is doing, that is essentially what value-based care and value-based payment is about. And it's important to ask yourself, how is that better than what we're doing right now? I want to just provide just a little bit of background and context for why are we talking about this at all? And that really is, in essence, economics, as well as, frankly, health outcomes overall. But let's talk about the economics first. And probably doesn't come as a surprise to you all if you're, paying attention at all to healthcare spending in our country. We spend far more than any other country, and frankly, get much poorer outcomes than other countries. And that dichotomy, that mismatch, is growing and again has real human consequences as well as financial consequences. It's estimated that about half, almost 40% of the annual healthcare spend in the US of $4.3 trillion is a good portion of that is wasted. In other words, it is paid for care that is either ineffective or inappropriate for the conditions and the situations out there. And that's perhaps surprising, unless you have tried to guide a family member perhaps through the healthcare system. Like I tried to guide my mom through the healthcare system when I first started with Aledade, and I thought I knew how to guide her through the healthcare system. And oh my goodness, the healthcare system was an animal of it in and of itself that I could not control as well as I thought. And there was all sorts of stuff done in that situation that I thought that I would be able to steer clear of. That's the kind of stuff that leads to this estimate of what is considered really waste, right? So there's a bunch of stuff happening that we don't want to happen. What's the policy reason or the policy pathway to fix this problem? And that is really, in essence, for a lot of policymakers and payers, primary care. That's the answer. So I went over problems, and again, this kind of outlines some of those things that are important to fix or address if we are trying to make a healthcare system work better for patients, to improve their outcomes, to help them maneuver through the healthcare system better. And these are really system-based problems. Before I was talking about practice-based problems, these are really system-based problems that are important to address or be aware of when we're thinking about doing things differently. So, and why is primary care the answer? So when we look at data, which I mentioned as a practice problem, primary care, what we've done for so long is try and pull all the strings of the healthcare system together, sometimes a lot of times with faxed records and all sorts of different things, and putting together a comprehensive picture of the patient and their family and their community, not just their illness or their organ or procedure, but that whole comprehensive picture, which has taken a lot of work, takes a lot of work. But that disconnected data problem is a real systems problem in trying for the system to do the right thing. A fragmented care, again, happened significantly in my mom's situation, I could tell you. Even though she got care in a healthcare system that should have been well connected, she really needed a good primary care doctor who really did pull pieces together and got their team to pull the pieces together and be the quarterback of her care. And primary care can do that if they are given the tools to do that. And then finally, sort of the problem in the healthcare system of misaligned incentives. So again, it probably doesn't come as a surprise to you all that, boy, incentives pull all sorts of different directions in the healthcare system. We have clinicians who are paid to see patients as often as possible and do as much to them as possible. And we have the opposite, which is people are paid to see them as little as possible and do as little as possible for them or to them. Both by the same, clinician. They're paid two different ways. We have health systems that, and hospitals that, they have to keep their beds full. Like that's how they make money. That's how they keep the lights on. And if they don't have that patient flow like we had in COVID, for things like elective procedures, what happens? There's a lot of cost to that system. And so their incentives are to keep that going and not really worry so much about keeping people out of the hospital or away from procedures. Rather, they sort of would like that to happen so that they can keep the doors open. It's an understandable financial problem. Primary care is really at the heart of the solution here in being able to, again, pull these pieces together and really take responsibility for the patients that are yours, that you are PCP for, and try and again help navigate the system. And right now, historically, primary care has not been incentivized. If we do a really good job of caring for folks and keeping them healthy, there really has been no incentive, or little incentive for us to have a reward as a result. And that has been the current state. However, accountable care organizations, or ACOs, are a policy strategy that's used by Medicare and frankly some other payers as well, many other payers, to address this problem and start to try and align incentives a little bit better so that primary care and folks that care about keeping people healthy and out of the hospital if they don't need it, that those folks are rewarded when that actually happens. Accountable care organizations are, again, essentially like the foundation of the value-based care model for Medicare specifically, and again, for many other payers, whether it's a commercial contract or other types of contracts. It is really difficult for a large payer to identify or work with a single clinic very effectively because of just sort of size and numbers and things like that. And so what an ACO does is essentially it's a group of organizations, so practices, for example, who all agree to essentially work together in some shared agreement to try and improve care coordination, try and improve the care that people get overall, the quality of care that they get. And as a result of doing that good work, the cost will be lower for those patients. So that's what an ACO is essentially, is just a grouping of organizations, again, usually in our case, clinics or practices that all work together under this agreement. So where the payer comes in, or how they interact, is essentially they interact with the ACO. So they have a contract with that ACO or big group of clinics. This is not, this is the ACO then passes those dollars on to the clinics based on essentially what the agreement is. So basically the payer doesn't have to interact with, 5 different clinics over there, because it's really hard for them to keep track of 5 things. They can keep track of one thing and have the dollars flow one way, and then actually be able to assess overall on a more relevant and appropriate population health basis, what is the quality of that population? What is their ability to keep people out of the hospital when it's not necessary for them to go? What is their ability to address cost? If the ACO doesn't exist and the payer, again, just interacts with these individual clinics, if one of those clinics has 1 or 2 patients with really bad cancer, their costs could be really, really high and throw everything off. That sort of is diluted, that effect or possibility is diluted by, again, having the group together in the ACO with a set of accountable rules, and the payer to be able to understand what that relationship is, and again, have the numbers and the financial ability to account for the dollars that flow to pay for better care. So hopefully that's starting to make sense, that basics of what an ACO is, why it exists, and why it is important, rather than just having, again, the payer interact with all the different clinics in Riverside. Ideally, then, this group of clinics, group of practices, works together and, again, is supported with things that they can share together, that they don't have probably the ability independently to buy or, be able to finance or budget, but as a group, with help, they can do things like get data and have analytics, be able to sift that data and present to them the opportunities that are actually going to make the biggest difference, instead of sort of being bombarded with data that they can't tell what to do with. They can do things like identify strategies, technologies, people support that can improve how practices actually run and function, and how patient outreach is done and how effective that is. And again, minimize sort of staff demands if they do that together. They can also do things like have strategies to deal with really complex patients, like nurse care managers, sort of roles like that, pharmacists, et cetera, that again can serve that whole group. But any one of them would not be able to fund a pharmacist or a care manager on site, in their clinic. But with a small group, they can work together and actually improve care together, because they all benefit together. It's just a, floating all boats strategy. But it does depend on actually having those pieces either in place or putting those pieces in place in order to be successful, and not just have it be a loose sort of confederation of clinics that are together for financial purposes. That's not the goal. The goal is to actually change how the function works and have the finances follow. Where did ACOs come from? Accountable care organizations, they came from Medicare. And Medicare has in general, they sort of set the tone for what private insurers do and what the healthcare system does in general. And the Center for Medicare and Medicaid essentially funds Medicaid, so Medi-Cal in California, primarily through that same system or that same network. So Medicare has decided they are going to change again. A long time ago, they decided they're going to change how they pay for care, and they're going to stop paying as much for fee-for-service care or piecemeal care, and they want to put more money towards accountable care organizations and driving accountable care overall to improve the, how the people under that care actually, the services that they get and the outcomes that they have. Medicare, the way Medicare ACOs work, and again, the way pretty much any payer ACO works is they rely some on some quality metrics. For example, there's different sorts of payment in addition potentially to fee-for-service payment, and where the accountable part comes in is in risk. And that is a financial risk, essentially, is what we're talking about here, where that group, that ACO, Accountable Care Organization, that group of clinics, shares financial responsibility with the payer for the costs of the care for patients who get the care in those clinics, okay? So that can be done two different ways. That can be done in what's called an upside only risk model, which means that if the ACO ends up saving money, yay, a percentage of that money gets sent back to them. That's great. Upside risk. They can only benefit in that situation. They can't lose. So if costs come in higher than expected, they won't have to pay anything back in an upside only risk model. Okay. So that's pretty much all upside, right? All benefit, no downside, right? In a downside risk model, there's risk both ways, usually in terms of if the costs come in below what was expected, then dollars get sent back to the ACO and the clinics. If they come in above what was expected, then that ACO has to pay money to cover some of those costs, right? And so, but essentially, ACOs work. The positive side of ACOs, when we are successful, which, again, we hope to be most of the time, right, is that we get shared savings, which is what the difference is between what the payer expects to spend and what is actually spent, right? So if that happens, costs come in below what was expected, those dollars get sent back as shared savings. But there is a difference in the upside and downside risk models, and that is important to understand if you are working in an ACO. Are you in an ACO that is an upside only risk model? Or are you in an ACO where you have potential downside risk? That is really critical to understand. So I want to just pivot a little bit and just talk a little bit about what we know from ACOs over the last 10 years or so. So I mentioned ACOs were started by Medicare a long time ago, meaning after the Affordable Care Act passed, that really set up ACOs in the what's called the Medicare Shared Savings Program, and Medicare has done a bunch of sort of experiments through the Center for Medicare and Medicaid Innovation to try and figure out like what's going to work when we're moving from paying fee for service piecemeal to paying for value. How is that actually done effectively, and what difference do different strategies make? So when they started ACOs, they've been doing this for about 10 years, and now we have really a good timeline of data that shows us what happens in different situations with the outcomes of those ACOs. And so there are a variety of things that have been found, a variety of articles. The one quoted here is from 2022 in the New England Journal of Medicine. But essentially what it showed was a really significant difference between hospital-led ACOs and physician-led ACOs. And in hospital-led ACOs, there were certainly some that saved money, but many were not saving money or were not saving nearly as much money as the physician-led ACOs. And the theory is that hospital-led ACOs just, again, financially have weaker incentives to lower costs. They have beds to fill. They bought a bunch of equipment. They have infrastructure to support. And so potentially have weaker incentives. That seems to play out in the data. Whereas physician-led ACOs, like the ones that Aledade works with, that we run, essentially, if we're talking about primary care, we're not losing money if people don't go to the hospital. That's a good thing for us. We like that. That's what we went into this career for, is to keep people out of the hospital. And so we have a big incentive if we do that well and then get paid to do that well. That's like this, virtuous cycle that we, again, went into this work for. So the idea is that because we're able to focus in a physician-led ACO, primary care focused ACO, on doing what's good for the patients and clinicians and society, that is what leads to the better outcomes. That is the theory. Again, in sort of thinking about, is this move to an ACO or value-based care better than what we've been doing? It is important to think about having support, right? That's, again, why I went into this work, is to provide folks support. But for whoever you are working with, it's important to understand that you should have support. And it's also important to understand, again, folks who looked at this, this has been around for a while. So there are ideas and strategies and evidence behind what is important to be successful in an ACO. And so from this national organization, the Patient-Centered Primary Care Collaborative, they're laid out in their 2018 evidence report. There were 6 different sort of foundations of, or characteristics of, a successful ACO generally. And so when you look at yourself and you look at, again, potential partnerships, think about what your strengths and weaknesses are, and where that potential partner could fit in to help ensure that you have things that are listed on this slide, like having the leadership and culture that actually can communicate effectively and ensure that there is change, and that ensures that you can do things like align incentives within the organization to do this work, that you have a health IT infrastructure, or the partner can provide a health IT infrastructure that augments yours to, again, ensure you have data and information about your patients that you're trying to keep healthy that you don't have right now. Other things on here, like proven success and prior experience, are really important as well. Especially now, there are a lot of folks in especially the Medicare space. And at the same time, in California, in Medicaid, we have essentially Medicaid ACOs that are forming, coming in 2024. So we have commercial, Medicaid, Medicare, Medicare Advantage. Everybody's essentially doing this work in this space. And so ensuring that you have folks that can navigate this really complicated space, that are your partners, that are helping you, and you don't have to reinvent the wheel, that is important as well. And then finally, again, thinking about the community you work with and the people around you, and whether or not there's an opportunity to, again, have a collaborative relationship with not only primary care, but even, again, into specialty care, right? Our subspecialists, which are so critical to that whole patient experience and outcomes. How do we interact with those folks differently, and what are the, again, organizational or environmental or community factors that either support that or actually inhibit that? It's important to really recognize that as you're thinking about where you are, and where you want to go, what is it that's going to help you get there, especially in that value-based care, value-based payment space? It is clear to me, after doing this work for 20 years, that this is the way things are going to go in the future, regardless of who the payer is. And frankly, around the world, where they're paying fee for service, they're trying to figure out this same thing and move in the same direction, regardless of how healthcare is financed at the government or policy level. And so we're, in many ways, in a cutting edge space, and potentially, in a space where we can help shape what comes next. And I was having a conversation with a group of clinicians a couple weeks ago, family doctors and residents and internal medicine folks, few pharmacists, et cetera. And we were really just talking about where, the conversation we were trying to have is, where are we going from here? Because again, the feeling is there's a lot of burnout in in primary care. There's not enough folks coming into primary care. A lot of us aren't sure how things are going to go forward and whether or not we'll be replaced by a bot or something like that. I mean, who knows? And at the same time, we're in rebuilding space post-COVID, and these are opportunities that we have to know about and take advantage of. And we have to have that rooted in key things that just make this work sustainable. So this slide sort of just outlines a variety, really, those key buckets that we find are really critical, that I have found over my career working with hundreds of practices are just really critical in making sure they continue to do this work and do it effectively without burning out, right? And so I'll share just a little bit on some of these about what we do with our practices and what we're learning in that space. But the first one I want to just start with is that one up in the upper left, is that autonomy piece, overall autonomy. And this is, this is a driver of all clinicians, is autonomy. It turns out it's a driver of everyone, right? Autonomy, the ability to control our future and have some say in decision-making. It's frankly why we find it effective to work with practices we work with, because they do tend to have more autonomy and drive sometimes. But we really, want to foster that autonomy and foster that nimbleness and foster that innovative thinking and put those wheels on the ground and actually get them to bite, to move things forward. That's what we want. We don't necessarily want to standardize the world and measure everything to the minute detail. Rather, we just need to give some folks some autonomy and some resources and foster that innovation, and then get those folks together. So, bringing folks in these groups together to learn from each other, so that they don't all have to reinvent the wheel, but they can actually benefit from each other. That to them is feeling like they have autonomy to then change care for patients when they learn. Enhanced revenue, again, really critical. So what we've learned historically is that I wonder if anybody knows what the amount of primary care each dollar spent on healthcare, how much of that goes to primary care? I'm curious if anybody puts that in the chat before I answer it. What I can tell you, so there's lots of evidence about this. I'll repeat the question. What percentage of the dollar, each healthcare dollar in the US, is spent on primary care? Or how many cents on each dollar is spent on primary care? What I can tell you, we're seeing if anybody gives an answer, I'll give it at the end, is it's not enough. Not with primary care as the only part of the healthcare system which shows across populations to lead to better outcomes and better equity. Oh, Melissa Bishop, bing. 5 to 7 cents on every dollar is spent in primary care. So I just said, primary care is the only part of the healthcare system, and evidence supports this. National Academy of Medicine just put out a report about this in 2021. Primary care is the only part of the healthcare system that across populations leads to better healthcare outcomes and better equity. And we're spending 5 to 7 cents of every dollar on primary care. That is inadequate, right? There needs to be much more invested in primary care, and that is not going to come through fee-for-service. It's just, it's not. That is clearly the direction from every payer across the board. So where are those dollars going? They're going into this value-based care, these ACO work. And so when we can send folks back dollars that they have earned through keeping people healthy, they feel good about that. And it's dollars they can spend on staffing and bonuses for their teams to keep them there. Data and technology, I'll also mention, we have a strategy of pulling together all the different threads of data to present it in a way that you can use it as the patient's coming in, or your team can use it for population health sort of, outreach and keeping track of who are my patients with severe hypertension, and do they have an appointment coming up? Those sorts of questions that are population health questions, that's really critical to know when your patients are in the hospital, when they're seeing specialists, when they're, again, different things are happening to them, to be able to manage their chronic diseases in a way that is effective. That has to be a critical part, and it is not in any EHR that I have found. I currently use Epic, highly functional Epic, and there's stuff that is missing in Epic because people get care outside of Epic sometimes. So even in the most high functioning EHR, you still need some other strategy to pull the pieces together. And then finally, I'll say supporting your workforce. Aledade does have a strategy that is both really important and not enough, but really important to reach into residencies and help support residencies, residents rather, with education around practice management and leadership and value-based care education, so that they come out really being able to run and work in, as a partner, an independent practice. And we help them actually land in places that are partner practices, so that, again, there's some workforce pipeline to help address this real workforce shortage. There has to be more than that. There's funding at the state level, for example, that is really critical to help support workforce pipeline across many different parts of primary care. But overall, this is like that must happen in order for the rest of it to work. I'll just, again, give you a little bit more about Aledade, and just mention that I mentioned where the practices that I have been working with to this point are located there on the West Coast. We are across the country at this point. Actually, Wisconsin should be colored. Before I moved to Riverside, I lived in Wisconsin. That's why I'm keeping track of Wisconsin there. So we just got our first practice in Wisconsin. And so we're all over. And again, that breadth helps us be able to connect folks together, again, across a lot of space. It also helps us be able to finance this work and take on any downside risk from our clinics. So the way we work is we don't have our clinics have any downside risk when I explain that upside downside risk thing. And that's really helped by actually having the scale that we have. Again, I want to really make the point, as you're thinking about this, as you're moving in this direction, hopefully, really be cognizant of where you are now. And I think that's the, one of the key wrap-up points. Just assessing where you are now, what is working, and specifically what is not working as well, is really critical, right? So when you're having trouble accessing data on your patients that are seen outside of your EHR or the local hospital or whatever, and you're finding out things about them like, oh, it turns out that they're getting care at a podiatrist who's treating them for a foot ulcer I didn't even know about. Those sorts of things are real stories that happen, and people find out about them when they actually get that data in front of them. But having data that's inaccessible, not knowing when your patients are in the hospital, it's really hard to solve the problem of, following up on their hospitalization when you don't know they're there in the first place, right? So that inaccessible clinical data is one piece, and I'll say, in many respects, it's sometimes overload of clinical data. So, for example, where I work clinically still a little bit, if my patient's seen in the emergency room, I get notified not one, but 3 times. With all exactly the same notes. But my team, who would be the ones to reach out to the patients, is not notified at all. Again, in my highly functional medical record, I cannot answer that question that I posed earlier, which is, who are my patients who have severe hypertension? And when was the last time I was checked? Do they have an appointment coming up? I would need an analyst to answer that question. So being able to get the answers to those questions and making things not just about getting the data, being able to use the data is one of the key challenges. That is caused by essentially a lot of different things, but one of the main ones is our lack of system integration, right? We all have, many of us have different EHRs. You'll have in a 5 or 10 mile radius, you'll have a good handful of EHRs. And so the ability to link into the systems and not just decide, okay, everybody's going to use Epic, or everybody's going to use one EHR as the solution, that's just not reality. At the same time, need to have a way, because the federal government didn't mandate this, I wish they had, but we need to have a way to ensure that data flows on the back end and we get what we need so it is effective and effectively used, right? So that lack of system integration, where you work locally and who you work with, that's clearly affected, right? I find a lot of folks in the outdated practice workflows and frankly, fragmented care delivery, as well as limited internal resources, all those bottom ones, those bottom three, all took a beating during COVID, right? I'll speak to practice workflows first. You know, a lot of folks, when I was having the conversation that I mentioned with that group of clinicians, multidisciplinary group a week or so ago, about where do we want to go from here, a lot of folks sort of remembered that, oh, back in like 2015, 2016, we had some strategy that actually worked for a couple things. And then during COVID, everything fell apart and we just forgot how to do stuff. There's turnover, and now nobody really remembers how to get the processes back in place. So we're at a rebuilding time, and it is so critical for things like blood pressure and really, everything. But blood pressure is a great example of how getting the process right ensures that better quality care will be given. And so we have to think about, where have all our processes frayed and how we're going to get those back on track, right? That's a big thing to think about. Limited internal resources, again, like I mentioned, I won't harp on it, but boy, everyone is overburdened. People are burned out from COVID. People are short-staffed. There's been all sorts of turnover. People aren't sure who's leading what, and the processes aren't in place. So that's a big lift for folks to rebuild. And it is what we do after disasters. It's what we do after a tornado or hurricane or flood or an earthquake or COVID pandemic. And so that's where we are. The fragmented care delivery has been there longer than COVID, right? So that's something that we've struggled with longer than COVID. And I feel like COVID has really, as again, turnover and processes have fallen apart, has had things become more fragmented. So where we used to have good specialty communication with certain specialists, for example, we lost that. So those are all challenges that are real. And again, important to actually be upfront about, think about, and address as you're trying to move to a better place. Again, where we fit in, where Aledade fits in, is trying to pull all those disparate pieces together and really, honestly, try and address those things that I listed as problems as much as we are able to upfront. So again, in the data space, I think that's where, it's sort of the most stark example. Doesn't really matter, with very few exceptions, what EHR you're using, but we will essentially connect with that EHR and connect all sorts of different types of data together to give a picture for you and your team about who your patients are, who's coming in, and who needs to come in or needs outreach to get better care. And that includes things like, again, scheduling and clinical data from your EHR, data from pharmacies that, it's not the fax from the payer that comes 3 weeks after you already refilled the medication. It's an actual history that shows you when folks are not taking their diabetes medication appropriately. We get data from payers around care gaps and things like that, patient information, put it all together again in a strategy that you can utilize. And we actually help you figure out how to utilize it in your practice. So it is never a one-size-fits-all strategy. It's one of the things I learned early on in this work is each practice is unique. And there is not one or two right ways to do things. However, this is a framework that can really help you define workflows, identify chronic diseases that are yet to be addressed during the year by anyone in the healthcare system, that sort of thing that can be really useful on a patient-by-patient basis as well as for your population. We generally just couch the work that we do in this, what we call our core four, which really is a really is the center of the conversation we have with folks. It's the sort of the why and the what and how in many ways of our conversations with folks, and really starts in that access and quality space, which is, making sure that people actually can access primary care, that they can get wellness, they can get U.S. Preventive Services recommended task force screening for their age. And so when we work on that with folks, that makes a huge difference. Access is probably the most evidence-based part of primary care. And many of the practices that we work with across California are in underserved areas. And so that difference is real. And when people get that access, and then they actually have their health risks assessed, and there's sort of that risk stratification over to the right there, of assessing, okay, what are this person's chronic illnesses, and how should we address their illnesses over the year effectively in a proactive way rather than a reactive way? How can we actually do things that again make an impact ahead of the problem rather than behind the problem? If we do that, then we find that we can actually help people manage and navigate through the healthcare system better when they have advanced kidney disease, or they have, the need for advanced care planning. They are moving into the specialty system, or they have medications that they're not sure how to use because they have hypertension and diabetes and high cholesterol, none of which cause symptoms if you don't take the medicine. And so why should they take the medicine? Helping people with those things helps them navigate the healthcare system in that care compass space. And that should then lead to fewer hospitalizations and fewer ER visits, because hospitalizations and ER visits, when they are unnecessary, are traumatic, independent of the cost that they result in. So this work, when we focus in those areas, access, quality, risk, helping people move through the healthcare system, we find we do make a difference in reducing hospitalizations and ED visits. And then the person can come back for that wellness visit again. We can make sure they get their screening, and the cycle continues. If you have concerns with your practice, with your clinics, and you wonder where is the place to go, and you don't have these things like a bunch of extra money sitting around in case you have downside risk in a contract and don't know how to fund that. You don't have great data analysts on staff that can provide you with reports on demand. You want, someone to call when you have a question about things. If those things are what you're looking for, again, find a partner that works for you. We are one partner. There are others out there. But really, these, again, should be the basis of what you're looking for when you want to enter into these contracts or expand your participation in these types of contracts. So I will mention that for Medicare ACOs, there is a deadline to sign up. Each year, Medicare sets a deadline. The deadline this year is August 1st, 2023. That is the drop dead date. There is no leverage past that date. So I would suggest signing up before this deadline if you are interested. If you are interested, you can scan this QR code. You can go to the website. We'll send out information in follow-up, and Sandy will send out and let y'all know who you can contact. But I will be happy to take any questions that people have about ACOs in general, support you may need, value-based care, etc.
All right, Dr. Saulino, we do have a couple of questions for you. So how does this apply to specialists?
Yeah, great question. So specialists, I have worked with cardiologists, for example, who's very interested in value-based care because they want to do a great job of taking care of their patients. And they realize they don't really want to be seeing patients for basic blood pressure management, or once a patient's really stable, they're excited about the really complex situations. That's why they went into cardiology. And so their group as a whole has participated in an ACO with a group of primary care clinicians to share patient risk, again, between them, because that fits with the direction they wanted to move. And because they've both done a good job, primary care and specialists, in managing patients, on communicating and coordinating, on handing off patients, not letting people fall through the cracks. They've done really well financially. You just need specialists and primary care to be on the same page, and then specialists, regardless of the specialty, can really be valuable participants in this sort of model.
And what's required for practices to join Aledade ACO?
Essentially, the willingness to participate and to do the work. And the work is work that you may already be doing, but you may not. But it fits into those core 4 things of doing wellness work and helping people manage their health risks and helping them navigate through the healthcare system and keep them out of the hospital. So that's the essence. Again, the timing matters. So I would say if you are curious about sort of the nuts and bolts, there's contracts to sign and conversations to be had, things like that. Start that process earlier rather than later. Again, that August 1st deadline is immovable by anyone that I know of. And so, but essentially it's the willingness to engage. And frankly, to me, that is what makes a difference in success once people start. If they did it because, I don't know, it seemed like a good idea and they signed a contract but didn't really think about it, and they're not really engaged, then when we are working with them, it's really hard for them to be successful. On the other hand, if they jump in and they're like, yes, this is the direction things are going, we do want to care for our patients better, we do need resources, and we're happy to just figure it out, we can help them figure out with wherever they start how to be successful. It's really that engagement that is critical.
Okay. And since there's an August 1st deadline, what would be and obviously there's contracts to sign and everything, what would be the deadline for them to join?
I would say, so I think there is a sort of preliminary deadline by May 30th. So again, like that's a nice guide to say, okay, probably good for you to have at least started having the conversations by May 30th. So that you can think about it and make sure all the T's are crossed, I's are dotted, and everything before August 1st. There's no harm in doing it earlier. There's only harm in waiting, in that you miss out on a whole nother year.
And then last question, can you clarify what support you'd be giving to practices as part of your ACO?
So it really fits into 3 buckets. One is, I would put it in the data and technology bucket. So we have again, technology that links to EHR, links to hospitals, links to pharmacies, links to the payer to get claims, et cetera, and sort of pulls it all together in something that your team can utilize. Regardless of what you're using right now, it can integrate and fit together with that. So we don't try and sort of like supplant anything if you don't want it. So the data piece is really significant. And the value of that depends on where you are now. Right? So if you're really well connected now and have a lot of resources and have a lot of data, then it's less valuable. If you are not connected, it's amazingly valuable. The other piece is really in people. So for each practice has what's called a practice transformation specialist or practice coach. They are a local person who works with a small subset of the practices to help you do your work and meets with your team pretty frequently, like couple times a month, or I mean, really as needed. And then there's that operations support. They'll work with your management, your front office team. They'll train people. They'll do all sorts of stuff. And then there's the clinical side, which is my side, which is the clinical engagement side. So we'll connect the dots for your clinicians, help connect them together so that they can have a community of support. Really answer clinical questions. So what we find is the clinical and operations synergy is where things work the best. And then finally, the last is financing. So we help clinics. So the clinics we work with do not take downside risk. So we finance downside risk, meaning that you will never have to pay back money. That is the current situation. The company hasn't told me anything different. Well, that's the situation. We take downside risk. And so that takes a burden off of practices in that they can win, but they can't really lose except by spending time doing this good work. So that's really a critical piece that is not present in all situations and for all partners, and a really critical piece that especially smaller organizations really just have to be aware of.